Why is my pals? Welcome on in. Where's my music? Hold on. Okay. Okay, we good. Okay, so we're gonna get started. We grabbing our daily heart. We liking the live pals. What's going on? Sweet type of love. Oh my God. Blessed believer, welcome on in. Good evening, everybody. Thank you for. Oh, let me post it to my thing. Let me get it going. Thank you, everybody, for joining on in early. Thumbs up in the chat if the audio is good. Once I get going, I'm gonna put my put the microphone on. Hold on, I'm coming. Let me just send this out and let me post it to my story. Dr. Shelter, welcome on in. Lux, I see you. Welcome on in. Add to my story. Lux with our borders, thank you so much for being here. I appreciate you. We are just getting started. We're liking the live. Once we get to 6,000 likes, we've updated it. We're at 6K likes now. Once we get to 6K likes, we're going to go ahead and get started. We're going to go ahead with our trending topic in healthcare. Then we're going to do our interviewed guests, and then we're going to wrap up with Professor Tips. So y'all sit back. We tapping the live, grabbing our daily heart, me reposting, and getting to 6K likes. Once we get to 6K likes, we're going to go ahead and get started on segment 1, which is our trending topic in healthcare. Okay, where am I going to be reading this from? Everybody, as we're waiting, as we're tapping, a quick check-in. How's everybody doing? It's Tuesday. We're still at the beginning of the week. Lux with our borders, how are you doing? How's your week treating you so far? I see you dancing, pals. Drop in the chat. How are you doing? How is the week treating you so far? Who else is in here? Dr. Shelter, I don't know. We're gonna do the trending topic in healthcare, and then we're gonna go over to our guest. So you do. I saw your message that you sent me, so you do have some time, okay, Dr. Shelter? I'm doing well. It's busy but productive. You know, it's busy but productive. I feel the same way too. It's busy but productive. Today I caught up on some grading. I had to send out some study guides. I had to organize my conference that I'm hosting at my school. Today it was busy but productive. Her Divine Alchemy, welcome on in. I see you. I hope you're doing well. I hope you're feeling better. You made it just in time. We're going to talk Her Divine Alchemy. We definitely going to talk because, you know, I definitely want to bring you back. But as you guys know, once we get to 6K likes, we're going to go ahead and get started on our trending topic in healthcare. Then we're going to get into our guest. Oh, you said you had a cancellation? Okay, Dr. Shelter, I see you. Pals, did you drop in the chat? How are you doing, pals? Coach Nan, welcome on in. I'm so glad you made it. You made it just in time. Welcome to Office Hours with Dr. Johnson. We're going to do our, I'm screaming. We're going to do our trending topic in healthcare. Then we're going to do our interviewed guests. Then we're going to wrap it up with some Professor Tips. I'm so glad you guys made it here in time. Once we get to 6K likes, I updated it. Once we get to 6K likes, I'm going to go ahead and get started. In the meantime, we're grabbing our daily heart, me reposting the live, liking the live, and we're jamming out until we get 6K. Uh-oh. Oh, I think this was an accident. Coach Nan, welcome on in. I think that was an accident. Thank you so much for being here.
No, wow, no problem.
Uh-oh. Divine Alchemy, I see you. Thank you so much. Dr. Shelter, I see you sharing out the live. Blessed Believer, thank you. Pals, did you tell me how you doing, Pals? Can I check in with you? Even though I know already, how are you doing, Pals? Oh, you said, oh, you okay, you ready to go home. Okay. I see you. Miss L Meek, I see you. Welcome on in. You made it just in time. We're getting to 6K likes. Once you get to 6K likes, we're going to go ahead and get started on our trending top. I'm screaming because the music is loud. Damn. Let me just sit back and just wait till we get to 6K. Out of breath and shit, like trying to overtalk over the music. Let me just sit back and relax until we get to 6K, because damn. Educator Hobbs, that's exactly where I got it. It's carnival season, so I got to keep up with my socas and my dancehall music. Educator Hobbs, welcome on in. I'm so glad you're here. You made it just in time. I'm not going to try to overtalk the music. We almost at 6K. Coach Nan, I see you liking the live. I appreciate you. Miss L, I see you sending out the live. I appreciate you. Educator Hobbs, I see you liking the live. I appreciate you. You know what? We at 6K, but then the mix is just about to get good, and now I gotta stop. Damn. Yeah. Oi. Oi. Okay, everybody, let's get professional. Let me update my jacket and tie. Welcome let me put the audio. Hold on. Give me a minute. This is a noise cancellation. How is the audio in the chat? Thumbs up in the chat if the audio is good. Thumbs up in the chat if the audio is good. Let me get my notes ready. Hold on. I'm getting kind of nervous. Folks is here on time. I'm nervous and shit. Hold on. Let me get right. Thumbs up in the chat if the audio is good. Dr. T, I see you. Welcome on in. We are just about to get started. Okay, the audio is good. I just put the mic on. The audio is good. Perfect. Okay, so let's go ahead and get started. We're gonna do. I have two trending topics in healthcare. Okay, I was doing some research and I found one. However, a couple people sent me this other one that I want to discuss. So we're going to discuss that one first. Pals, I see you, moderator. Trending topic. The first trending topic is 5 Black doctors are leading at Johns Hopkins University hospital. There's a university, but Johns Hopkins Hospital. Okay, so the trending topics in healthcare. We just breeze through them. Real news, real facts. We just briefly share with you what is going on and what we should be talking about instead of what we should not be talking about. Okay, so trending topic in healthcare: 5 Black doctors leading at Johns Hopkins Hospital. For the first time, I'm reading. I have a second screen, so that's why you guys see me looking away. I'm reading, bringing you guys real news, real facts, real information. Okay. For the first time in history, 5 Black doctors, and I'm going to say their names. It's important to say their names. I may butcher them. I got an accent. Don't judge me, but it's important to say the names of these 5 Black doctors. Okay, because this is history being made. Ivy Mano. Okay, Valentine Alia, Ife Shoyombo, Zach Inuma, and Lawrence Brown. Those 5 doctors will be leading the trauma and acute care at the prestigious Johns Hopkins Hospital. This groundbreaking appointment is a major milestone for representation in medicine, celebrating the talent of these 5 surgeons and inspiring future generations of Black doctors across the world. Do you see why it's important? Representation in healthcare is representation all around is important. But do you see why representation is important? Do you see how they ended? What do they say at the end? This groundbreaking appointment is a major milestone for representation in medicine, celebrating talent of these 5 surgeons and inspiring future generations of Black doctors across the world. Now, just a couple more facts and a couple more information. We all know Johns Hopkins, very prestigious hospital, okay? But this the same hospital where they had that situation with Henrietta Lacks, where they used her cells for cancer research without her consent. They did that quite a lot. Okay, so Johns Hopkins Hospital has been in the media for quite some time, even though it is a renowned hospital. John Hopkins Hospital has been in the media for quite some things and for quite some time. So yes, Henrietta Lacks, they used her cells for cancer research without her consent. Coach Nan, I see you. Yes, without her consent. But just to bring it back and me doing my research and finding out about this hospital and about this article, the comments were saying, John Hopkins, that's a real person. I'm gonna bring you guys some real facts. Who was John Hopkins? He was a Quaker businessman, investor, philanthropist, and a slave owner. Let's keep it a buck. Can we keep it a buck? Can I have two people drop the 100 sign in the chat? Can we keep it a buck? He was a Quaker businessman, an investor, a philanthropist, and he was a slave owner, allegedly. Okay, pals, I see you. Yeah, we're gonna keep it a buck. He was a slave owner. That's what the people them were saying in the chapter. He was a slave owner. So the reason why I bring that up, at one point, John Hopkins University Hospital did not want to take black patients. At one point in time, Johns Hopkins Hospital did not employ black doctors or black healthcare professionals. Dr. Shelter just said, and he married his cousin. That's dirty. No, excuse me. No disrespect to nobody who married. Well, no, your cousin. That's dirty. Excuse me. That's dirty. Thank you for sharing that, Dr. Shelter. Damn, you just threw me off. At one point in time, they did not like to employ black doctors and healthcare professionals. At one point in time, this hospital did not like to take black patients. Now look. Ren Patrice, I see you. Welcome on in. Now look. John Hopkins University has 5 black doctors leading their acute and trauma services at the hospital. That's major. That is major. It's critically important for trauma care, for patients, especially minoritized patients. Okay? It's important that your healthcare providers and your healthcare professionals look and sound like you. And these 5 black doctors look and sound like the majority of their patient population. And as I was doing research and as I was reviewing this article that they sent me, they were also in the comments saying, why are we saying African American? Say black. Why are we afraid to say black? So I'm coming on here and making sure I say black. These 5 black doctors, because ain't nothing wrong with saying the word black. Okay? I see you liking the live, Coach Nan. I see you. Pals, I see you. Thank you so much for your support. Ain't nothing wrong with saying the word black. Also, we're going to wrap that up. Ain't that good? Coach Nan said amen. Let me just make sure I didn't miss nothing in the chat. Hold on. Okay, and I just scroll back up to and he married his cousin comment. Dr. Shelter, I see you. Next, I want to breeze on to the next trending topic in healthcare, which was this just dropped last week. Okay. Why landing a doctor's appointment is such a headache. Okay. People don't have these jobs. People don't got no jobs. And there's a shortage. Okay. Hiring in corporate America may be sluggish, but hospitals are scrambling for talents. There's a lot of discourse online saying, I'm looking for a job. I don't have no job. I'm applying. It's not just you. And I'm telling people it's not just you. It's everywhere. It's America. Hiring in corporate America may be sluggish, but hospitals specifically, they are scrambling for talents. Okay. It's a rare bright spot in a jobs landscape with limited openings, widespread hiring freezes, and an increasingly frustrated workforce. These hospitals are scrambling for talents. It also presents a major challenge for the medical field. For patients, it means longer wait times at the doctor's offices. They barely don't got no patient care techs or medical assistants or front desk receptionists in the front. Okay, they're not hiring these new grads. Those are perfect jobs for these new grads who want in-person or clinical experience. For clinics, it means they can see fewer patients, jeopardizing their bottom line. A new report from the healthcare education platform Covista found that hospital leaders are falling noticeably short in filling positions across the U.S., especially in roles people seek out most, such as primary care. People them don't got no jobs. And that's wild. Okay? Just briefly, thank you, pals. I see you. Just briefly going through that. The 5 black doctors who are leading Johns Hopkins Hospital and now hospitals in need of talent. That's wild. That's wild. We're gonna wrap up this trending topic because we could keep it going, and I can tell you, I could take it to a place where we gotta take it to a place. Let me bring up my guest. Give me a moment. I forgot how to do this. Oh, Oh, okay. Oh, I almost just panicked for a minute. I almost forgot how to. The devil is a lie. Elaine, I see you. Welcome on in. Blessed believer, I see you liking the live. Welcome on in. Dr. Shelter, I just sent you a request. Did it go through? Dr. T, I see you. Thank you, Coach. Now I don't know what to do. Hold on. I'm gonna cancel. I can't even. Okay, I'm gonna cancel it. Okay, I just canceled it. Now, Dr. Shelter, you request up. Let me see if that will work. If that don't work, what we gonna do? Dr. T, happy Tuesday to you as well too. I see you, Dr. T. Oh, okay, there we go. Oh, Jesus. Oh, God is good. Oh, feel the devil try to work, figure something. Oh, Coach Nan, I see you. Oh, Dr. Shelter, Miss Melissa, welcome on in. Welcome on in. Dr. Shelter, how are you doing? Everybody in the chat, is the audio good? Thumbs up in the chat if the audio is good. You know, sometimes when you bring on a guest, the audio get kind of wonky. Is the audio still good?
Hey,
Oh,
Dr. T, so nice
yeah,
to see
Dr.
you.
T is excited to see you. Melissa, I see you. Thank you so much for stopping by. Melissa, I'm going to send you a message. I have to discuss something with you, Melissa. Thank you so much for stopping by. Dr. Shelter, first and foremost, thank you so much for taking the time to step into office hours with Dr. Johnson. I appreciate you. A lot of you guys, I'm sure you guys know, Dr. Shelter was originally supposed to speak for one of my previous um, conferences, but you know, life be life. And so I just want to make sure that you are good now and everything you guess what? That I don't even want to say if you're good now because that I didn't want to put your business out there like that because I don't even know if you posted it online. Did you? You didn't post it online. You did. You did not.
I didn't post it, but I'm
Okay.
okay to talk about it. So my
Because
best
you're
friend passed away in a
okay.
really, really traumatic way, and it
Mm,
just threw all of us for a loop. So I was out, down for the count.
okay.
But thank goodness for community support, lots of
Okay.
love all around. You know, I'm back on my grind. That's how she would have wanted it.
Exactly. Amen. Because guess we're not. Dr. Shelter, thank you so much for being here. Okay, ma'am, I appreciate you. I appreciate you for taking the time. I know you said you got a busy schedule. Yeah, they're sending you hugs and amen in the chat. But first and foremost, I just
Thank
want you to,
you.
I want you to start off with your educational and professional background. You know, this is social media, so whatever you don't feel comfortable sharing online, you know, we're healthcare professionals. We know how to use context clues and et cetera, et cetera. So, you could start us with your educational and professional background. Then we're going to get into these questions because you know I did my homework.
Absolutely, absolutely. So, yes, I have my PhD in clinical and community psychology. I obtained those at the University of Maryland. And prior to that, I earned two master's degrees, one in clinical psychology, clinical track, and then another one in clinical psychology research track. So I have a ton of experience with research in the clinical field. So that is my academic background.
I love that. Thank you so much for sharing that. Now, before we continue, you guys know the drill. A thumbs up or a praying hands. Normally, a thumbs up is just me acknowledging you guys in the chat. I don't want to interrupt my guests or throw them off. And guests, I just want you to know if you see me doing a thumbs up, I'm not trying to rush you. I'm telling the people them thank you. I see their comments or their gifts or whatever or have you. I'm just acknowledging them with the thumbs up. Okay, because in the past I was doing thumbs up and the other person was like, "You want me to stop?" I was like, "No, I'm not. I ain't talking to you." But Dr. Shelter, thank you so much. We're gonna jump right into it. So I had sent you some questions briefly, just kind of prepare you for what we're going to discuss today. So I have some topics relating to mental health and social services. We're going to briefly discuss some topics on cultural competency and the importance of cultural competency in healthcare. Then we're going to briefly go over misdiagnoses. That happens a lot. A lot of people get misdiagnosed quite a lot. We're also going to get into mental health and minorities. Us black and brown folks, we don't like therapy. Why do we not like therapy? We're going to briefly get into that. And then we're also going to get into some awareness and advocacy as it relates to mental health. Dr. J, I see you. Welcome on in. I just want to jump right into it, Dr. Shelter. as it relates to social services, okay, what are some of the biggest barriers that individuals in underrepresented communities face when accessing mental health services from your experience?
Barriers. Well, there's the issue related to managed care and
Mm-hmm.
insurance challenges, right? One of the biggest challenges is that a lot of insurance companies cap their reimbursement rates to therapists. And so therapists, let's say, might charge $300 a session.
Yep.
Insurance companies might reimburse $120. Right. And so it means that the amount that they bill and the amount that they pay doesn't line up. The math ain't quite mathing, as they say. And so a lot of times individuals will stop taking insurance because it's not worth it to them. And so a lot of people do need to use insurance in order to get services, and yet insurance companies don't reimburse enough for it to be worthwhile. And so a lot of times folks are just not taking insurance. And so people can't pay out of pocket. Those rates are really high. Another issue is also related to there's not enough mental health professionals available. So wait lists tend to be very, very long. So even if a person recognizes immediately that they are in crisis and are in need of support, you're going to get a up to 6-month wait list for therapy services, not to mention a year to a year and a half wait list for assessment services. So there's that problem. And to add to the challenge of the shortage of clinicians within the field is that there's the pipeline to get more clinicians in is already has so many systemic barriers that make it difficult for people to get in. And once they're in, the licensing exams are incredibly prohibitive in terms of the cost and how difficult they are to pass. And so there's people that have had to take that licensing exam 4, 5, 6 times at $800 a pop, right? And so people are available, but the barrier of that exam and how difficult they make it just makes it so that there is a shortage all around. So those are just some. I mean, there's plenty more. We could make this whole life about barriers if we wanted to.
We can. Thank you so much for sharing. Before we continue, can I have 2 people drop in the chat subject matter expert? Do y'all see why Dr. Shelter is here? Can I have 2 people drop subject matter expert stickers in the chat before we continue? I also want to highlight what Lux Without Borders just said. She said, especially in the IDD community. What is the IDD community? Intellectually, it's a tongue twister for me. Intellectually developmentally disabled, correct? Yes, right? IDD, the IDD community. Intellectually developmentally disabled community. There's lots of barriers within there. There definitely is. Thank you so much for sharing that and highlighting that. Dr. Shelter. Okay, I see Dr. J dropping the mental health stickers. Okay, Coach, now with my subject. Perfect. Okay, I see the stickers. We can continue. Y'all are amazing. Thank you so much. Dr. Shelter, we just jumped right into the interview questions, but can you break down your background as it relates to your niche in psychology? So you said you are a licensed clinical and community psychologist. Break it down for us. What if we don't know what that is? Community psychologist? Man,
I know. I thought about that.
Yeah. What is that? And what do you... Hello, take it away. Ma'am, take it away.
Yes, I thought about that after I was like, I have my PhD. What else do you need to know? But I was like, wait, there's so much more that I could say about that. And so clinical psychology has to do with treatment of mental health disorders. Specifically, we focus on psychopathology, identifying mental systems that are not working okay, and utilizing empirically validated treatment modalities to work with individuals to bring mental health equilibrium. Okay, so we deal with the mind and the emotions. That's the clinical aspect. The community aspect has to do with the health of our communities and how systems influence the health of individuals within communities. We tend to focus a lot on prevention programs, intervention programs that target groups of individuals. We also utilize things like program evaluation and things to make sure that programs that have been implemented are effective and doing what they're supposed to do, and that we're seeing the outcomes that we said we want to see. And so when you combine clinical and community psychology, I think that is the holy grail of mental health treatment, because we understand that the individual exists within context, meaning that you can't treat an individual without understanding their context. And so oftentimes we're looking to see what is the person's race, what is the person's age, does a person live in a rural or an urban environment, and how do the various contextual factors associated with where they're located, how do they impact an individual? We're also very much into intersectionality, which is thinking about how various dimensions of diversity intersect and interact with one another to create unique conditions for individuals that impact them specifically. And so when you work with a clinical psychologist who is community trained, you're really getting the best of both worlds, because I can talk to you about how we feel about systems that oppress us, as well as talk about how are we going to create change, and how do we advocate, how do we fight injustices, but at the same time, what are you going to do to make yourself feel better while we work towards changing and revolutionizing those systems?
Right. Y'all, I'm smiling because you see, I love when I'm speaking to I love when I'm speaking to my subject matter experts. And when you have a vision and you invite somebody on, or you plan something and it's being executed, I normally say that at the end of the lives, they already saying in the chat, this is great.
Yeah.
Dr. Shelter, once again, thank you so much for being here. I came on your live a couple of times. I watched a couple of your videos and I said, you know what? You share the same passion as me. And I love how you speak. I love how you are once again a subject matter expert in your field, and it shows. Continue to show up. This is I'm going to tell this to you at the end, but I'm just telling you, while as you're speaking and as you're breaking it down for us, it's just bringing a smile to my face. I love intelligent people. I love people who are passionate about the work that they do. I love when you see somebody who is enjoying what they do in life. So thank you so much for enjoying what you're doing in life and sharing what you enjoy to do. Okay, ma'am?
Thank you so much for saying that. I felt myself come alive, right, when you asked me that question, because it combines all of the things that I am passionate about, that I really care about, and I don't just know it intellectually, I live it, from the depths of my soul.
Exactly. Thank you so much for sharing that. So I want to stay on the topic of community-based services. So how can community-based mental health services be improved to better serve marginalized groups? Us as Black healthcare professionals, at the top of our list is marginalized groups. Okay. So once again, I'll repeat the question for you. How can community-based mental health services be improved to better serve marginalized groups?
Yeah. So that's a very deep and nuanced question. And I think it comes back to the topic of communities and the context in which communities are situated. When we do community psychology, we typically will go into a community and figure out what they need from the community themselves, right? Which is different from people in the ivory tower coming down to the community and saying, this is what you need. And so a lot of our focus is about going into the communities, speaking with the leaders of the communities, the people who live within those communities, and finding out what it is that they need. And then working in conjunction with community members to develop treatment programs that meet the needs that they have identified, as well as combining our expertise. And so I think about when you're implementing a program, we have what's known as a logic model. A logic model is the framework that you utilize for developing programs, and you have inputs and you have processes, and then you have outputs. And so if we know the community is going to give the inputs of they know their area and what they need the most, and they are saying what outputs they want to see. We, as the experts, then sort of cook the middle to say,
Mm-hmm.
well, what would that look like? So we've taken their opinion, their expertise of their community, as well as what they would like to see, and we're implementing that in tandem with them. They are what we know as stakeholders within the community.
Right.
It's also super important to ensure that they are involved in the process too as we go along, right? So even though we're the ones cooking the middle of it, we still want to make sure, does this program make sense? Does this curriculum make sense? This language that we're using, is that going to attract people, or is that going to be off-putting, and things like that, getting their input into the programs that we're bringing into their community.
Right. Thank you so much for breaking that down. I just want to address a couple of things in the chat. Dr. J was asking, is there going to be a replay? Yes, it is posted after all of my office hours are posted on YT. Oh, perfect. My moderator got me. Oh, my moderator got me. Lux Without Borders said, meeting them where they are by addressing the barriers that exist with that community and households. That is important. That is key. Oftentimes, people don't meet their patient population where they need to be at. Dr. Lewis, I see you. Welcome on in. Let's continue. We're going to wrap up the section of mental health and social services. We got a lot of topics to discuss. I'm so excited. Everybody, if you're just joining on in, welcome. Today in Office Hours with Dr. Johnson, we are interviewing Dr. Shelter, a licensed clinical and community psychologist. Okay. A subject matter expert. Okay. Can I have one person drop my subject matter expert sticker in the chat, please? Just one person. And then we're going to continue. Once I see that one sticker, we're going to continue. We're going to give Dr. Shelter her flowers. Can I have this one person drop the subject matter expert? Lux Without Borders, I see you. Miss Nike, I appreciate you. Thank you so much, L. I see you. Dr. Shelter, this question is from your personal experience, okay? Dr. Henry, I see you. Welcome on in. What strategies do you find most effective when working with individuals who are hesitant to seek mental health help due to the stigma or fear? We speak about this a lot, okay? And we may sound like a broken record.
Yeah.
This needs to be a broken record, okay? And I'll repeat the question, okay? What strategies do you find most effective when working with individuals who are hesitant to seek mental health help due to stigma or fear?
Yeah. The question about strategies can be a little sticky for us as psychologists or clinicians, right? Because we are reluctant to answer that question directly because it assumes that there's a set of things that you can do to get a person there.
Right.
But really, it comes down to treatment approach, right? It comes down to concepts like establishing rapport. It comes down to concepts like culturally competent care, and really tailoring your approach to the individual and their particular needs. And so a lot of times when you work with people from marginalized communities, you have to understand that things like cultural mistrust exist, right? And those things are valid based on the history of how the systems and organizations have treated certain individuals, right?
Exactly.
And so them being suspicious of the establishment is valid and relevant. And so rather than pathologizing that and treating them as if they're resistant to treatment, you want to validate the reality of that and allow the person to take the lead in terms of their comfort and when they're ready to share certain things. And that is really more of an art than it is a checklist of strategies of how to do that, right? Because we are relational in our approach and we are working with the individual and meeting them where they are. And so why that question becomes difficult to answer is because 20 people will present differently, 100 people, 5 people. And so the approach that I take with each individual is going to be different. But I think the main point is establishing that therapeutic alliance, and each person is going to do that differently. What works for you might not work for the next person, but what works for the next person, and so forth. And so we really do keep it relational as our first and foremost approach, so that you meet the person where they are, validate their concerns, and walk with them systematically until they get to a place where they are comfortable.
Exactly. Thank you so much for breaking that down. Yep, they said individualized plan. Build that trust. Exactly. I want to get into the topic of
Yeah.
cultural competency, like you said, and marginalized groups. Everybody who is just joining on in, welcome. Today I'm interviewing Dr.
Yeah.
Shelter. She is a licensed clinical and community psychologist. Frame greetings. I see you. Welcome on in. Um, Dr. Henry, I saw you level up. I appreciate you for being here. Regal Miss Nike, I see you liking the live. Coach Nan, I see you engaging in the chat. Lux Without Borders, I see you engaging in the chat. I appreciate you guys all for being here. Let's continue. We're going to get into cultural competency and marginalized groups. Okay, so how do you ensure that your clinical practice is culturally competent when working with clients from diverse backgrounds? This is healthcare. We all are not going to have the same one
Yeah.
type of patient, the one patient. So once again, how do you ensure your clinical practice is culturally competent when working with clients from diverse backgrounds?
Training.
Okay.
Training. I can't
Okay.
say that enough.
Okay.
Yes, because you need to ensure that you are trained and understand the various issues related to diversity that are important. One
Right.
thing that I like to say is that you can't assume that just because you're going to understand all things related to diversity, right? There's various dimensions of diversity. If you're using Pamela Hayes's framework, called the addressing model, which breaks down social constructs of diversity. We have diversity according to age, developmental disabilities, race and ethnicity, socioeconomic status, sexual orientation, indigenous status, nation of origin, and
Right.
gender. Right. And so while you might occupy some social dimensions, you're not going to occupy all of them and be an expert in all forms of diversity, which is why the next important thing is cultural humility, right? Cultural humility in saying, while I might be an expert in this particular social group because of my own lived experience and being located within that group, I'm not an expert in all of the things. And so when I maintain cultural humility, the client then becomes the expert of
Right.
their lived experience, and I am walking alongside them. Now, at no point is it ever the responsibility of the
Mm-hmm.
client to educate me about their particular lived experience, but I certainly will make them the expert of their personal experience, and then I do everything I can to learn about that. So I love to give this example of how I once worked with a young woman who spirituality was very important to her. And so she has this on the intake, and I thought, oh yeah, great, spirituality. I love spirituality. Do you know that her spiritual beliefs were centered around sacred geometry? And at the time I said, oh, that's great, right? I don't know anything about it, have no idea how she orients her life within that. And so I had to validate that as being important to her. And then I had to go and educate myself, research it. What are the main, tenets of this belief, and how does the client utilize this and make meaning in her life? And how do our treatment goals align with this
Right.
particular spiritual belief? And so I say that intentionally because I am of Zimbabwean origin. And so, being in America, the Black experience is very heterogeneous. We all come from different places and have different lived experiences. And so again, I want to always remain humble in recognizing and acknowledging that my lived experience does not equate to somebody else's experience. And so I must maintain a spirit of humility in order to then work with people where they're at and meet their individual needs.
Right. I love that. Thank you so much for sharing that. Once again, every time she speaks, I need someone to drop a subject matter expert sticker in the chat. After every time Dr. Shelter drops her response, yeah, just clear your throat, ma'am. Hydrate yourself as they drop the subject matter sticker in the chat. I need a subject matter sticker in the chat. Subject matter expert sticker
Thank
in
you
the
for that.
chat. Thank you so much. We're gonna continue. We gotta give her flowers. Braids, I see you. Thank you so much. Welcome on in. The Cassandra, I see you liking the live. Welcome. Thank you so much for being here. I want to stay on the topic of cultural competency for a little bit longer. I want to touch on one more thing, okay? Can you speak to the importance of
Yeah.
understanding a client's cultural context when diagnosing and treating mental health conditions?
Yes, that is
Yeah.
so important.
Mm-hmm.
We use the Diagnostic Statistical Manual of Disorders version. We're on the 5th version now.
Right.
And this is a manual that contains all the mental health disorders developed by the American Psychiatric Association. And when we diagnose an individual, we look at the diagnostic criteria within that to determine how much of those diagnostic criteria a person meets in order to be diagnosed with something. Now, there are things known as cultural expressions, meaning that the way that a Black woman manifests depression is going to be different from the way a white woman would manifest depression.
Okay.
And so you have to then have awareness that as I go through the 9 diagnostic criteria of depression and I ask, my client, a Black woman, about sadness, their sadness might show up as irritability, right? But that doesn't mean that their sadness is any less valid than the typical way we would expect to see sadness, right? And so when you understand cultural expressions of symptoms, then you can more effectively identify an individual's symptomatology in order to be able to diagnose them effectively. Secondly, there are sometimes cultural expressions that are not pathological, that tend to be pathologized by a Eurocentric model of treatment. And so if you come from a lens of understanding and valuing diversity, you might understand that a person who says, yes, I hear things that other people can't hear. Whereas traditional psychology might then quickly diagnose that person with delusions and hallucinations, another person might ask, tell me about when you hear these things. What is the context? And a person will say, oh yeah, when I'm talking to the Holy Spirit, right? I'm sitting in a room and I'm worried about a situation. I'll talk to the Holy Spirit quietly and he'll talk to me and tell me everything's going to be all right. Now, if I did not understand diversity as it relates to religious expression of spiritual practices, I then might diagnose them as having some hallucination or paranoid ideation. And so when you understand various expressions and what they mean in different cultures, then you're less likely to make that mistake of misdiagnosing individuals. Now, that experience and expertise does come with practice, which is why our training is so rigorous and requires years and years of supervised practice in order for you to learn things. And I promise you, we made a lot of mistakes during our training, but that experiential learning is actually the most effective in integrating and learning, because you're never going to make that mistake again. And you've now put it in your tool box to be able to pass on as you train other people as well.
I have to clear my throat. Did you guys see me leaning into? Okay, they already dropped. I need one more subject. Okay, they dropped the subject matter expert. I love to see the passion. Dr. Shelter, thank you so much for being here. I love the work. I appreciate the work that you're doing. The work that you're doing is important. It's crucial. It is needed within our marginalized group. So thank you so much for showing up every day. Okay. We are going to get into misdiagnosis. Okay. Because speaking about misdiagnosis is important in healthcare overall. Okay. Right. So, in your experience, how does systemic bias impact the likelihood of misdiagnoses in people of color or other minority groups? I want to take it there from straight off the jump. Peel the skin off. Professionally.
Yeah. So bias is going to impact how marginalized or minoritized groups are treated left, right, and center. and often creates problems not only as it relates to misdiagnosis, but even as it relates to even the therapeutic alliance, the effectiveness of treatment, even utilizing the correct treatment and things like that. And so when it comes to misdiagnosis, a lot of times it is due to a lack of cultural competence within specific groups of individuals. We're not going to say who all, but certain groups are more likely to misdiagnose because our treatment model is Eurocentric in its origin, in its structure, and in its how we're taught it. And unless you've made an intentional effort to seek out understanding of alternative expressions of symptomatology, you're always going to think that this is the way that it's done, such that even folks who are of a certain hue can also make that same mistake. Everybody can be subject to that mistake unless you make the intentional effort of learning what that presentation looks like.
Right.
And so misdiagnosis most often occurs among people of color, for example, when they are working with individuals and use words like resistant to care or that they are combative, right? Words like that are, what do they call it? Dog whistles, right? They're dog whistles that symbolize a certain thing within certain groups. And if you use a word like resistant to treatment, it means that everybody that sees that later on is going to go, well, it's a lost cause. They're resistant to treatment. But we talked about cultural mistrust, which is healthy and appropriate. What if you looked at the fact that they might be exhibiting cultural mistrust, a healthy expression of cultural mistrust, and you approach them differently? What might you label that? If you were to use the word hesitant, for example, that has a very different tone than resistant.
It does.
And so the word bias, you're coming back to your original question, is that the words that are used to describe minoritized communities are certain dog whistles that lead to them being treated a certain way throughout the system. But if you are culturally competent and aware that words have meaning and weight, you're going to be careful how you word that. And so the word resistant, before you label a Black person as being resistant, for example, think about what the implications, the cultural implications of what that bias, the use of that word is, what that means for that person's record and how they'll be treated in subsequent settings. And so understanding that bias, it occurs in media, bias occurs in education, bias occurs across the board, and these systems sort of feed into each other so that by the time you get to clinician and client, it's not even just my own bias that influences how I treat the client. It is the system's bias that influences how I treat the client, and I have to fight against that. Even as a Black clinician, have to fight against what the system has fed me to be able to utilize the right terminology that is affirming and supportive of a person's lived experience.
I love that. Thank you so much for breaking that down. Once again, can I have 2 people drop subject matter expert in the chat? Like I said, after every time she gives her response, I need subject matter expert stickers in the chat. Miss KL, welcome on in. I see you. Leah Unfiltered, welcome on in. I see you. Miss Renita Drakes, I see you. Welcome on in. Welcome to Office Hours with Dr. Johnson. Today I'm interviewing another subject matter expert, Dr. Shelter. She is a licensed clinical and community psychologist. Okay. I want to go off the tangent a little bit. I do have my questions here, but I want to ask you something, right? As I'm connecting with other healthcare professionals, and also as I am teaching so many different courses within healthcare admin and community health, I'm speaking with people who are saying, Dr. Johnson, I was never diagnosed with ADHD on time, or I was misdiagnosed for something else, and all I really had was ADHD. That's part of why I wasn't able to, fully succeed in school or hold down a job.
Yeah.
Specifically as it relates to ADHD, do you feel as though not enough people are properly diagnosed with ADHD? Let's take it there.
Well,
Be
I had to pause for a second.
yeah, pause and be
I had to
transparent.
pause for a second.
At Office Hours with Dr.
Yes,
Johnson, we always keep it a buck. We always are
yes.
transparent. Okay, she ready. Welcome
Let me
on in.
see
I
who
see
all's
you,
in your audience. Look, I don't even know who's in the FYP, so I'm like, do I say what I want to say
ma'am.
or
That's why
not?
you're here. That's
All
why I
right,
invited you. Say
let's
it.
go there.
Say
Let's
it.
go there. So it is true that in the past, people were less likely to be diagnosed with neurodivergence disorders like ADHD or even autism.
Okay.
Part of it was that it wasn't well known. So when you think about the 80s, for example, were people really being diagnosed with autism and ADHD like that back then?
Right.
Chances are they weren't for several reasons. I think that healthcare has come a long way. Our systems and even the fact that DSMs get updated, right? That all has come a long way, which now allows things to be caught sooner and more on time. But I also think there's a generational difference when you think about in the 80s, the millennials parents would have been boomers, and boomers are known for sort of being about their business, making money, suck it up, yeah, I've fed you and I've given you, all the resources you need, what more do you want from me? But they weren't really attentive to a person's emotional and behavioral experiences to be able to appropriately seek services if a person needed it.
Right.
So there's that part where things weren't getting caught across the board for everybody. And fast forward to now, 40 years later, everybody is now being diagnosed with ADHD and some neurodivergence or another. The question then becomes, did we experience a 500% increase in rates or prevalence rates? Or is two things happening? We are able to better identify things, but now also we're lumping in things that aren't ADHD because we have so much awareness of it. And so people are going to rush to be like, oh yeah, there goes my ADHD. Or even the way people casually use OCD, obsessive compulsive disorder. Oh yeah, I'm really OCD. I love things to be clean. That's actually not what it means. But again, there's now pop psychology makes certain things popular and folks are now seeking out specific diagnoses. And if you meet diagnostic criteria, it's very easy to get an ADHD diagnosis now. Now, the challenge that I am encounter, because I do what are known as comprehensive psychological evaluations. These are extensive batteries where we test a person psychologically to determine what do you even have. Sure, a person can present with a specific presenting concern and say, I need to be tested for ADHD. I'm going to test you for ADHD right? I'm not going to just say, is it ADHD? Ask the diagnostic criteria. Yeah, you meet it. I'm going to test for anxiety, depression, personality disorders, and do a collateral interview and a clinical interview. And I'm going to correlate that data and say, what does this person truly have? And in that context, I've had so many people come in for ADHD diagnosis, but it turns out to be depression. And people are very angry at that because we come from a history where ADHD was not being caught to now it's too many people saying it's ADHD, but there's other things that also exist. So to reemphasize the discussion too about ADHD symptoms sometimes being mistaken for depression symptoms sometimes being mistaken for ADHD. There are various expressions of depression symptoms. You got your physical symptoms, you got your emotional symptoms, and you got your cognitive symptoms. So your cognitive symptoms of depression are memory difficulty, executive functioning difficulties, brain fog, inability to concentrate, inattentiveness, irritability, psychomotor agitation, like Do you see
Okay.
what I'm saying here?
Yes.
And so
Okay.
if a person's experiencing those things and they say, I have ADHD, and I simply give a battery test or screener for ADHD, I can say, yes, it is. But if you come to a psychologist who does a comprehensive evaluation, I'm like, wait, hold on. You also said you were sad and you're not eating and you're not
Right.
sleeping.
Right.
I'm now seeing the whole story in a way that I can say, I know you think it's ADHD, but I promise you it's depression. And the report is a 20-page report that will explain why. So I am seeing more of that. So that's why I had to pause about, do I want to go there? Because that makes people very upset, because it's almost as if I'm hearkening back to the 80s and saying, oh, you don't really have depression. But I'm like, oh, I mean, you don't really have ADHD. I'm like, yeah, but I think that you don't.
Right. Right. Thank
I
you.
don't think you do, right? Because I've
Right.
done this comprehensive evaluation with a battery of multiple assessment measures that help me then see the whole picture to be able to identify and diagnose you effectively.
Right. I love.
Yeah.
You guys know what to do. She just wrapped it up. You guys know what to do. I need 2 stickers, subject matter expert. Dr. Lewis, hang tight, Dr. Lewis. Educated and opinion in the chat said, at what age is a differential saying depression? Is there more to that
Yeah, I don't
question?
know what that question means. I saw that question, but I didn't understand. There might be a word missing there
Yeah, there
or
might
a
be a word
typo.
missing, but educated and opinion. Make sure you educated an opinion. Drop your opinion in the
Yeah.
chat. I'll look for it and I'll come back to you. Okay, educated and opinion. Everybody in the
Yes, ask
chat.
your question differently.
Yeah, maybe word it differently. Dr. Lewis, I see you. Looks Without Borders historical perspective is valuable comparison. Yes, it is. Leah, I'm so glad you're here. She said she's happy she made this convo. I'm happy you made it too, and
Yeah.
I'm happy.
Yeah, even collateral data. So
Right.
another thing that's important is you might have difficulty functioning at your job, but you're okay at school. You're okay at home, right? So collateral data will help us to see, where does this behavior manifest? And so
Right.
an interview and collateral data helps you to get a clearer picture.
Exactly. Thank you for
Don't say
saying that.
extra words. Look, if you say extra words, I got something to say about that
I
too.
know. So that's what we're just gonna stick to the script. We're gonna stick to the script, Dr. Schultz. We're gonna stick to the script.
Yes.
Okay.
Mhm.
Everybody who's here so far, we've gone over mental health in minorities. We've gone over misdiagnoses in mental health. We've gone over cultural competency. We've gone over social services in mental health. Now we're gonna get into mental health in awareness and advocacy in mental health. Okay. So, no, excuse me. I skipped minorities. I skipped you and I. Sorry. We're getting into mental health in minorities. And I want to take it, we're peeling the skin back. We're digging deep. We're taking it somewhere, okay? I want to continue taking it somewhere because my chat likes the transparency and they appreciate real conversations. Nia, I see you. Welcome on in. Thank you so much. But Dr. Shelter, you may have to breathe on this one, but how does historical trauma affect mental health in minority communities? And what role does it play in contemporary mental health challenges? I want to take it there because I feel as though it's important, because us as black and brown folks, we do have we have experienced historical trauma. I'm gonna sit back. They want me to lean in. I'm gonna sit back. I'm gonna let you take it away, but they may want me to lean
Look,
in.
I'm ready. I stay ready.
And that's why, ma'am, that's why you're here. That's why you are here.
Listen. So, historical trauma is one of my favorite topics. I happen to know a lot about this. It was included in my dissertation. Okay, right. So we are already going there.
I told you I do my homework. Ma'am, I do my homework.
Of historical trauma. Let me just. Yes, apparently, I'm quite impressed.
Thank you. I appreciate you. Thank you.
All right, so historical trauma has to do with the fact that we call it transgenerational transmission of trauma. This research was initially done amongst Native Americans and amongst Jewish Holocaust survivors. Mm-hmm. And the idea is that a history of trauma can be embedded epigenetically, such that subsequent generations will have expressions of that trauma as if they are experiencing that trauma. They also did animal research on it, where they worked on mice in a lab, rats in a lab, and they subjected the rats to various stressors within a lab context and measured their stress responses and the genetic expressions of stress. And they found that 7 generations later, those offspring were still reacting as if they were traumatized by the event that's traumatized the individuals. So the animal research gave us an understanding of how that manifests within human beings. After they had done research on Native Americans and Jewish Holocaust survivors and their offspring, people turned around and said, wait, hold on. Who else has a really long and sordid history of trauma? What about African Americans? There's a brilliant book by Dr. Joy DeGruy known as Post-Traumatic Slave Syndrome. I'm not crazy about the name, but she named it what she named it. But the idea is that African Americans in the United States, descendants of chattel slavery, experienced horrors and stressors of slavery in generations past. And when individuals were freed, when emancipation came along, they said to them, oh, you're free to go. Good luck. But did they give them and say, oh man, that was really rough. We treated you terribly. Let us make up for it. Let us give you some therapy. Let us treat you and let us, all the ways that this might have harmed you. No, people were just released. And so behaviors and things that were learned during slavery have continued to perpetuate even beyond, being set free. For example, and this is an example that Dr. DeGruy gives that I love. She says that there's a white mom and a black mom. They're at a baseball game, and the black mom says to the white mom, wow, Johnny's doing really good lately. He's, doing so well on the field and his grades are good. And the white mom says, oh, Tyreek is also doing really well. In fact, I think he had higher scores than Johnny. And the black mom will say, oh, he don't know nothing. He's a hot mess and he's, giving me a lot of trouble. And Tyreek is hearing that going, wait, what? Why would you say that? And now they feel sad and they feel devalued and criticized and all of these things. What folks in that setting don't understand, and what mom might not even understand, is that back in slavery, 2 little kids of 10 years old playing together, one black, one white. If they were to look at the black kid and say, wow, he sure is getting strong, it means that they're going to transition from being a kid to now you're going to do big responsibilities and hardship and things like that. And so within the black culture, we learn to sort of downplay our kids' awesomeness so that they would leave them alone. But years later, we've carried that on. It is a trauma response that was necessary back then, but now is a pathological expression, and it is harmful. And if you were to now challenge mom on that, she's not going to understand that, because that mom loves her son and she values him, she feeds him, all of those things. But to now say, when you said that in front of those people, it made me feel that way. That's what we mean by the transgenerational transmission of trauma. That is a trauma and that is a response. It's not like people are playing out scenes from the 1600s and acting a certain way. No, this is how that transmits. And this is how it harms people to this day. Right. Transgenerational transmission of trauma is passed down not only biologically, it's also passed down socially. Social learning. Mm-hmm. What we see our daddy do is what we gonna do. It is also passed down through expression. So you ever heard the old folks say, oh, my nerves are bad, right? Mm-hmm. My nerves are bad could actually mean that you're hypervigilant, hyperreactive, have anxiety, but we call it nerves. And we say, you getting on my nerves, and feel like I can talk crazy or throw something at my kid. And because we call it nerves, we haven't examined it as, hey, you're kind of hyperreactive. You're kind of having these expressions that need attention. You actually need to do something about it rather than just, this is just the way that I am. So there's so much I could say about it. I don't know. Which way do you want me to go with this? I could go, many different directions, but that's the groundwork to help us understand historical trauma and how it manifests within the Black community in the US today. Now, there's people that are from the diaspora. You could look at the same type of expression amongst the Caribbean folks. So you could also look at the same expression among African folks that were colonized, right? And how, for colonized people from colonized countries, when English was brought and education and A-levels and things were brought, your performance on those things determined your ability to work and to be labeled a good Black, right? Do we still continue on those kinds of things where a lot of African people, proximity to whiteness is very important for us, but we have to understand where that comes from, and wanting to be different from everybody else. That comes from that colonialist history that said you had to set yourself apart and compete amongst other Black people because there's only 4 teacher jobs available at the top. And so the more white you can act, the more likely you are to get that job. And thus proximity to whiteness then becomes the yardstick or the barometer of how good you are.
Mm-hmm. Mm-hmm. Do y'all see how she took us there? All I had to say was historical trauma, and Dr. Shelter was going to take off.
It's like activate.
She was going to activate. Everybody who's just joining on in, welcome. Thank you so much for being here. Today we're interviewing Dr. Shelter, just an all-around mental health subject matter expert, okay? Dr. Shelter, I want to ask you one more question as it relates to mental health in minorities, and then I want to, start wrapping things up because I know you're a busy woman. You got a lot to do. You got a lot of people to take care of. But what can mental health professionals do to address the intersectionality of race, gender, and socioeconomic status within their practice? Mm-hmm. And let me lean in because look, my chat is already telling me to lean in. So I'm gonna just already lean in. I'm gonna start listening to my chat. Let me just start leaning in because they're telling me to lean in.
Yeah. So intersectionality is a topic that is near and dear to my heart.
Yes, ma'am. Yes, ma'am.
And the reason why it's so important. Intersectionality is a term that was coined by Kimberly Crenshaw in the 80s. And Kimberly Crenshaw is an attorney, a lawyer. And they developed that term based on the fact that they worked with a lot of defendants who were experiencing racism and were experiencing sexism in a unique way that other defendants weren't experiencing, and wanted to find a way to articulate the multiplicative effect of having various dimensions of diversity and how they don't just add up, they multiply, right? So it's not that I have 3 dimensions of diversity on top of each other. It's multiplied and it's bigger than 3. It's like 9 or exponentially. That's what the word is. It increases exponentially. And so the idea then is that we now need to understand what the impact of that cumulative effect of those multiple dimensions of diversity are on one individual. And understanding the injustice that exists when you talk about just racism or just sexism or just socioeconomic status, because then you are leaving out important components. Not only that, right? On issues of, let's say, women's suffrage, right? The women's right to vote and feminism, right? White women would say to black women, well, we're not talking about race. We just need to unite as women so we can vote. But black women were saying, wait, but you are oppressing me and my needs and not allowing the expression of what race does in my life and not allowing that to be expressed within this setting. And so coming back to treatment and how that plays a role in treatment, you need to be able to hold those things at the same time. It's like a delicate art. Remember, I mentioned the word art before, where just because a person mentions the thing related to race, you have to be able to then tie it to what intersectionality would say and what the cumulative impact would be. Right. So that is an art and that is intentional. You can't teach that. You can't read that in a book. You have to really embody it in a way that I don't know that a lot of clinicians are able to do because it's very complex.
Right.
I once worked with a highly intelligent black man who was very, very intelligent and was navigating experiences of, anxiety within his context. And, the therapist had made a quick nod at race and how that might play a role, but didn't understand what it meant for this kid to be bused to another neighborhood to go to a good school because they're so smart. And what kind of unique racial socialization would need to occur for him to be able to operate in that context. Right. And how his parents, being a low SES, could not adequately teach or prepare him how to navigate in those circles. Right. And so this brilliant mind who's highly intelligent is now finding themselves experiencing this intersectionality related particularly for him to, race and socioeconomic status. Sure, he's a man and has that privilege, but as a child, there's the intersectionality of age, right? That really did a number on that person. Mm-hmm. But again, in therapy for a long time, for years, not ever understanding how the intersection and the of SES played a role, right? So the therapist was of a certain hue, did their due diligence in making a nod to race because they were trained in cultural competence, but intersectionality would have had them explore what that meant for that kid and how that has played a role even until now, to really start to dismantle some of the narrative that individual would have built up around who they are and their sense of belonging and all of those things, despite how intellectually brilliant they were.
Right. Right. Dr. Shelter, thank you so much for breaking that down. I want to bring up somebody in the chat, educated and opinionated in the chat. Can I don't know if it's you said, can you ask my question on depression and ADHD? Educated and opinion. Can I bring you up? You don't have to turn your camera on, but you can just, use your voice. You just utilize just the voice, the audio. So you could ask your question directly to Dr. Shelter, because I think it may be, I don't know. I think it may be, like blocking your question. You know how the chat can be. How do you? Okay, educated and opinion. Request to come up, and then I'll bring you up. You don't have to turn your camera on if you're not comfortable. But thank you so much for feeling that this is a safe space for you to ask about your son who's 9 years old. I see you. Educated and opinion. Thank you so much for being here. I realize you're a new follower. Thank you so much for supporting me. And once again, thank you so much for feeling comfortable to ask this question in front of all of us. This is a safe space, and this is the reason why I do what I do. So welcome and thank you so much for being here.
Thank you for having me. So this is from a mom perspective, not, from a professional stance, but I have a 9-year-old son, and he was diagnosed pretty early with ADHD, It's pretty moderate. But then last year, he received a high functioning autism ASD2 diagnosis. And I was listening to you speak about the possibility of it being depression. So I was saying, at what age do they differentiate the possibility of having ADHD versus depression?
Mm. Mm-hmm.
Oh, I see.
I
Okay.
see it now.
Yeah,
Okay.
that's a very nuanced question. Yeah, it's a very nuanced question, and you couldn't have typed all that in the chat. So I appreciate you coming up here
Yeah,
to say
thank
it
you.
with your words.
Mhm.
I don't know that there's an age necessarily, because I recall doing a similar assessment on a 9-year-old, right, and was able to identify depression. And so I was hesitant when I said that thing earlier about sometimes it's not ADHD, sometimes it's depression, because I don't want you to take that to the bank and say the TikTok psychologist said it's not ADHD.
Right.
Remember what I also said about context, about the number of batteries that they would have to give before they can diagnose that, the contextual, the clinical interview, the collateral data from teachers and daycare workers and parents at home and therapists, right? All of that data together should allow them to effectively make a diagnosis. I think what I was speaking to is maybe general practitioners, right? Your family doctor gave you a screener for ADHD and said, oh, yep, looks like you have ADHD. You need to go to a psychologist and do a comprehensive evaluation, which it sounds like your son had. Because when they do that, they give multiple batteries that help them elucidate and differentiate and rule out, right? What is what. And so if they didn't pick up depression, chances are it might not be there.
Thank you so much. No, he did go through a comprehensive assessment here in Virginia. And I had struggled, though, for years to get him diagnosed when we lived in Michigan, and ran into one wall after another. And they were saying that his behavior tendencies would mask his possibilities of being diagnosed with autism. And then coming here to Virginia, being aligned with a wonderful hospital here in Richmond, the doctor was able to really dig in and see the ADHD was an issue, but he was more so suffering from those social issues within the autistic diagnosis. Yeah.
Thank you so much for asking your question. Is there anything else while I still have you up here? Anything else you want to ask Dr. Shelter before I drop you down? What is your name? Do you have a name you want to? I don't want to just call you Educated and Opinion.
I'm Candy.
Okay, Candy. Anything else you want to ask the Dr. Shelter while you're up here, or you're good?
Oh, I'm good. Thank you so much, Dr. Shelter.
Okay, and I see them letters behind your name, MSNRN.
You're welcome.
I'm gonna follow you back. Candy, I'm definitely going to follow you back, and we're definitely going to be in touch. You know, I love to connect with various healthcare professionals, but just I see them big names, them credentials behind your name. So I'm definitely going to follow you back and stay connected. Okay.
Okay. Thank you so much.
Thank you so much. Oh, follow back. Okay. Let me go ahead and disconnect. Guess what, Dr. Shelter? That just brought up something new. Candy, thank you so much for doing that. This is the first time I've brought somebody up in an office hours to ask a question to my interviewee. Candy, thank you so much for spearheading that. I think I want to include that into my office hours. Candy, you are the best.
Yeah.
And so is your son. Don't give up on him. I heard
blaze the new trail.
Yeah, Candy, I heard like you seem as though, you know, you may be overwhelmed, or maybe you said stuck on a wall. Do not give up on your kid. Keep advocating for your kid. Okay. Do not give up on him. And just, I'm sure, you know, you're a healthcare professional too. There's nothing wrong with your kid that can't be fixed or that can't be helped with resources and I'm not sure if you're into medication, but resources, medication, and therapy. Okay. So just know that your kid is perfectly fine. He's just has a special abilities that need to be addressed. So I'm sure you know that, though. You're a healthcare professional. Dr. Shelter, thank you so much for answering the question and allowing me to bring her up. I appreciate you. Okay. I want to wrap up our last topic, which is mental health and advocacy and awareness, which kind of ties into what we just did with Candy. You know, the importance of awareness and the importance of advocacy. Okay. So Dr. Shelter, why do you think there is still a lack of awareness around mental health issues, particularly in certain communities like the Hispanic community, like the Black community, the Caribbean community? Why is there particularly within certain communities?
Yeah. Those are what we call cultures of honor,
Mm.
right? Cultures of honor really emphasize the importance of hierarchy and honoring your parents, honoring the elders.
Right.
And there's a lot of emphasis in children's upbringing that you don't question adults and adults are never wrong and you keep our business at home. So I'm summarizing that as
Right.
cultures of honor.
Right.
And so in cultures of honor, saying that I have a mental health problem is dishonoring my parents somehow, is
Whoa.
dishonoring my community somehow.
Whoa.
And so if I am going to be a good community member, I need to minimize my struggles so that I don't dishonor my community or my parents. For example, if I were to say I am sad and I'm depressed, a lot of times in cultures of honor, the response is, what do you have to be sad about? I clothe you and I feed you. I take care of you, don't I? Right? They immediately hear it as a criticism of them rather than even validating the child's expression and inquiring about what's going on. A child saying I need something or I didn't experience something or I didn't feel loved is an indictment on the parent. And in cultures of honor, they cannot tolerate the shame. So in cultures of honor, shame is the worst emotion amongst those cultures and those communities. So anything that brings shame is going to be very difficult to tolerate. We don't even have, even now within the Eurocentric model of traditional psychology, our treatment of shame is actually pretty new and hasn't been fully developed, let alone trying to now address shame within a culture that prioritizes shame as a social tool for control, right? I remember, well, it's about to be a long story. I'm not going to go there. But the point is, whenever shame is brought up, it is designed for you to quickly fall in line. So shame is the tool that they utilize in those cultures to keep people in line. And so anything that is seen as potentially bringing shame to the family is not going to be tolerated, will be quickly extinguished.
Right.
Yeah.
Right. Candy said in the chat, you have to break down the bondage of shame.
I mean,
Yes. Exactly. Them shackles of shame, break it down.
Yeah.
There is no judgment, which is a good segue into my next question. But what steps can communities take to normalize mental health discussions and make resources more accessible to those who need them? Let's take it there.
Yeah. Well, I feel like conversations such as this are super important, right?
Right.
This is a social media app. Thousands of people are just going to scroll through and pass by on our FYP. They see two beautiful brown people having a conversation. They're going to stop in and say, what's going on there?
Right.
And we are speaking, utilizing language that is accessible and we're casual in our approach, such that we are approachable and people can come in here and hear what we have to say. I think that's the first step. The term that we use in community psychology is called translation psychology, right? Where I want my services and my knowledge to be available to the public. So how do I translate what I know to make it digestible to the general public? How do I talk without sounding like I'm in the ivory tower talking to other researchers and trying to sound smarter? How smart can I sound? Right? You want to break it down for people to understand. You want to be accessible to people. I feel like more of us, healthcare professionals, need to be on platforms like this to do this kind of work. Right? But unfortunately, there is some risk associated with putting yourselves out there in this way. If I were to say something that somebody didn't like today, they're going to try to go and get my license taken. They're going to go to the Virginia Board of Psychologists and say, Dr. Shelter said this on social media, and try to take away my license. There'll be an investigation, etc. You know, those things are off-putting for a lot of professionals. And so a lot of times we'd rather not deal with it. But you have to learn. I mean, so I think there is such a thing as media literacy, social media literacy, how to engage questions. Like when educated and opinionated came up, I had to be careful how I responded to that question, because I don't want to seem like I'm giving you healthcare advice and it's recorded and now they're going to have something for us to you know, for them to use against me. So you have to train yourself in media literacy. And yes, I have made mistakes before, and I said, oh, don't do that again. But that's a risk that you take in order to train yourself and learn how to do this. I believe that at some point I am going to train other professionals on how to do media literacy and translate their research, their work that they do, to make it accessible to the general public. So clearly, this is an area of passion for me in terms of making this work accessible. And then I think another important thing is really centered around storytelling. Storytelling is a very important component of Black culture. We do storytelling in our music, in our comedy, in our poetry, and things like that. And those things are more likely to catch people's attention rather than just, here are 5 signs of ADHD. Tell a story about a person with ADHD and have when somebody reads that, they'll go, oh man, they can see themselves in it. So we need to start to do more storytelling. And I have some ideas about what I want to put out in that way too, to normalize what that looks like. And, you know, they jokingly say the best way to hide something from folks is to put it in writing. And so if we know this to be true, we want to make things accessible. How then can we tell stories in a way that allows them to reach the people who we want to hear it the most? And then finally, I think that the work that you do one-on-one is very important, because I believe that when I treat an individual and I make a difference in an individual's life, the changes that can occur in that person's life are enough to touch the people surrounding them. And so when I work with one person, I work with all my heart, because the 500 people in their circle are going to be impacted by the improvements in that one person. And so I really work hard to make sure that my individual sessions are impactful, and we're breaking down stigma, we're validating them, and we're hyping it up so that they're like, oh my God, you got to call my therapist. I have a ridiculously long wait list, because I work with so much passion and enthusiasm with each person so as to make an impact around them. And so at some point in my life, you know, I do a lot of community work, and sometimes you get caught up in the drudgery of it. Somebody reminded me that, please, you are doing God's work in that context, that the thing that you do with one-on-one clients is important. And that really shifted my mentality about the impact that you believe that you're making and how much you can destigmatize the field and make an impact so that they're telling more people. That's why I have a long wait list. Is destigmatization, right? Is Black folks that I work with that say, oh, I've got this Black therapist, you're gonna love her, right? And it just snowballs like that.
I love that. And guess what?
Please, I'm not taking any more clients like that.
Okay. Guess what? We see, as you are articulating and as you are sharing your professional experience, we see the passion, we hear the passion. I'm sure the chat sees that as well too, because they've said it numerous times in the interview. We see the passion, we hear it. So once again, thank you so much for the work that you do. Everybody who is just joining on in, today I'm interviewing Dr. Shelter, licensed clinical and community psychologist. We are wrapping up the segment of her interview. But just to briefly recap, we went over social services in mental health. We went over the importance of cultural competency in healthcare and mental health. We discussed misdiagnoses within mental health. And we also just finished up mental health in minorities and also awareness and advocacy. Now, I have the last two questions for this interview for Dr. Shelter. She knows what these are. But so we're talking about mental health. We got this, we got that. Do this, all these recommendations. What does Dr. Shelter do to stay on top of her mental health? Mm-hmm. Sure, let's all lean in.
What do I do?
Yeah, can I have two people drop the lean in sticker? And I see Crystal in the chat. She just said
Do I do anything?
she just had to close her caseload for the same reason. Yeah, so that means you a subject matter expert and you doing what you're doing, and the people that are around you recognize that. Kudos to you, Crystal. I see you in the chat.
Yes.
Okay, they dropped the lean in stickers. They ready for you. What does Dr. Shelter do to stay on top of her mental health?
Yeah. So believe it or not, I diversify my work. I've described and explained how doing full-time therapy is very burdensome, particularly for people like me that do it with all their heart, right? And so if I were to do that 40 hours a week, I don't know that I would have the energy and the passion that you see right now. I just would have enough to just crawl home and get into bed. So I learned a long time ago that I need to diversify the type of work that I do. So I do individual therapy. I do psychological evaluations, both clinical and forensic. And I teach undergraduate and graduate psychology, as well as chair dissertations.
Okay.
So that in and of itself is different kinds of work across, I don't want to say how many jobs I have, but across different settings, so that I am adequately challenged, engaged, and excited on a regular basis. So if I'm doing, of those 5 jobs, I'm doing 10 hours here, 10 hours there, 20 hours here, it keeps me sufficiently engaged and nimble and light to be able to engage all of those things with passion and excitement. If all I did was dissertation work, I would just be like, oh, another paper, right? But because I do many different kinds of, even my assessments, I do autism assessments, forensic assessments, and then I supervise clinical assessments, right? So I've got different ways that I engage in all of those things to keep me fresh and excited and nimble, I think is the word that I said earlier, and that's very relevant. I also use a lot of spiritual grounding, and this one has been most important in more recent years. I don't know that it was as developed in earlier times, but now I find that my walk with Christ has been so important in terms of balancing me and centering me. And really, the Holy Spirit is walking alongside me in sessions. So for example, if I'm doing a session and Holy Spirit drops some a word of knowledge or something like that, in the past, I might have gone, oh, I don't know, should I even ask that? And now 2 months later, we're still walking around in circles in that same thing. But now that I allow the Holy Spirit to walk alongside me, he drops a word of knowledge, I just say it right away. And how did you know? Right? And now we're in there, right? We're getting to the things faster. And it's less burdensome than me using my own might, right? If I am working with divine help and divine guidance in my journey, it's almost like it's not me anymore. It is God's work. Even when I have a hard time with a client, like, I almost, when I'm having a hard time with a client, I now know to pray. I go, geez, I don't know what's going on with them. I don't know what I'm going to do. Oh, I got session in 30 minutes. You know what? Let me go ahead and pray. And sure enough, thank goodness I prayed. Like it worked out. And yes, this person made a really good point about spiritual protection, because I was definitely unprotected and ungrounded for many years. And once you now recognize the need for spiritual boundaries and protection, you are able to stay pure and light, so that your light is what's shining through, not the, mud from everything else. It's your light that's radiating out.
I love
I
that.
could go on and on.
I love that. Thank you so much for sharing that and shedding light on that. I want to address two things in the chat. Crystal, you said I'm trying to find a way to diversify because this is a setup for burnout. Crystal, I see them credentials behind your name. I'm not sure if you also work within higher education, but you see, once I started working within higher education, it opened the doors for so many other opportunities. Aside from teaching and doing some of the other healthcare admin work that I'm doing, I'm also in the process of writing a textbook. But had I not been in the healthcare administration space, they wouldn't have approached me to be an author for a textbook to use in healthcare administration courses. That allows me to, once again, be nimble, touch here, touch there, so I'm not burnt out in one, said area. So definitely look into higher education if that's something you're interested in, Crystal. Also, I see Supreme Victorious in the chat. She said, I have a minor in, I'm not sure if it's a man or woman, I don't know, I can't tell the light. But Supreme Victoria said, I have a minor in psychology and I'm thinking about going back and get my master's degree in psychology. You better get that degree. We all know office hours of Dr. Johnson, we're always promoting getting that degree and going back to school. They can take so much away from us, but they can't take away your degree, your credentials, et cetera, et cetera. You better go back to school and get that degree. So the answer is yes. And I'm sure that the answer from Dr. Shelter is yes as well. Crystal said she's definitely interested in higher ed. Crystal, start off in adjuncting. Definitely start off with adjuncting. I see the LPC, the LMHC, and the LPCMH, all them credentials, you'll be good to within human services. There are lots of universities are always hiring for adjunct professors within human services or social services or even social work. Find you an adjunct job, and then they love to hire adjunct professors for full time. So just take that how you will. Okay, perfect. Okay, I just wanted to make sure I addressed that before you guys left because I have the last question to ask Dr. Shelter. Dr. Shelter, once again, thank you so much. But the last question for your interview, what is your overall why as it relates to the work that you do, as it relates to the reason why you continue to show up, as it relates to the reason why you are so passionate about the work that you do? What is Dr. Shelter's overall why?
I think that I have a responsibility. Is the one word that sums it up. I believe that I have a specific anointing and a particular anointing for healing and for teaching. And so to whom much is given, much is required.
Okay.
It is my responsibility to disseminate that, right? It is my responsibility to show up and to teach. It is my responsibility to explain. I've been teaching classes in the morning in one particular setting, and I was just amazed that people go, wow, this is so good, this is great information. I'm like, oh my gosh, bless their hearts. I almost felt bad, like I'm not doing it enough. People want this, right? And so that comes back to that word responsibility. It's really stirred something up in me to just be like, yeah, it's not enough to hoard all this knowledge and then just keep it to yourself. You have to disseminate it. So for me, it is a sense of moral and civic duty to, as well as really yielding to the Holy Spirit's leading about how it is that they want me to impact the world.
I love that. Dr. Shelter,
it's my ministry. I call it my ministry.
It definitely is. And it shows. It definitely shows. Dr. Shelter, once again, thank you so much for taking the time to step into office hours with Dr. Johnson. I appreciate you so much. The chat, I'm sure they appreciate you too. Before I drop Dr. Shelter down, can I just have a couple round of applause in the chat? Crystal said, I want to raise up the next generation of clinicians and decolonize this work. Definitely. We spoke about destigmatism that, yep. Doctor, I'm gonna have to have you put this on YouTube. I'm definitely gonna put this on YouTube. I definitely will. But just before, I just wanted Dr. Shelter to see her flowers before. Yes, ma'am. I'll share the link with you once I post it up. I just wanted you to see your flowers and the round of applause in the chat before I drop you down, ma'am. This was insightful. This was amazing. continue doing the work that you're doing. Continue showing up. I know you're just starting off on TikTok. Continue to show up. Your room will grow. Your page will grow. Do not get discouraged. You're a mental health professional. You know how to block out those negative thoughts. So continue to show up. If you need my support, if you need my help, you let me know, ma'am. I am here for you. I am locked in with you. I am locked in with all of my subject matter experts. They're in the chat saying we need you. So Dr. Shelter, thank you so much for showing up, and thank you so much for the work that you do. Okay, ma'am?
Wonderful. Thank you so much for having me. This was very exciting and a lot of fun, and thanks to your wonderful audience as well.
Yes, ma'am. I'm going to go ahead and drop you down so we can go ahead and go on to our next segment. Have a great day, ma'am.
All right. Thank you.
Okay, now, I'm telling you, today, this office hours, this was good. This was big because Candy, I don't know if Candy's still in the chat. She just started something new for me, bringing up a guest who may have a question for my interviewee. So Candy, if you're still in the chat, shout out to you, Candy. Thank you so much. I'm constantly trying to figure out how can I improve office hours with Dr. Johnson? What else can I do? Lux Without Borders, I saw in the chat earlier on, you was dropping your credentials and your area of nursing. I'm definitely going to reach out to you. I'm always reaching out to my healthcare professionals. Dr. T, you see this? Dr. T, you see why it's important to continue showing up? I was trying to figure out, I'm talking to myself, what can you do? What can you do? And Candy came into the chat and just brought me this idea. So I shout out to y'all. Once again, shout out to you guys getting me to over 140,000 likes. I appreciate you guys. You guys are amazing. I continue to do this because of y'all. Let me breathe. So you guys know, in Office Hours with Dr. Johnson, the first segment is a trending topic in healthcare. The second segment is my interview with a guest, a subject matter expert. And the third segment is a professor tips. Today, I'm going to switch things up. I'm going to have my colleague, Dr. Lewis, take over the professor tip. So let me bring up Dr. Lewis to go over the professor tip that she has for you guys today. Dr. Lewis, I don't know if you know how to request up, but Dr. Lewis, can you request up? I think you have to, you guys, what does she press? Does she press? No, she presses the two people or she presses the infinite. No. Dr. Lewis, okay, there you go. Thank you. Because Jean, no. Dr. Lewis, can you hear me? Can you see me?
Yes, I can. I can hear you. I can't. Well,
We can't see you. No, we can't. Okay, we can see you now.
Hello.
Okay, perfect. How is the audio? Thumbs up in the chat if the audio is good. Thumbs up in the chat if the audio is good. You know, when you bring on folks, the audio gets kind of wonky. I just want to make sure we're still good with the audio. A couple of thumbs up in the chat.
I hear you perfectly. Chat
Perfect.
is blooming.
Okay, perfect. I see the thumbs up coming on in. So you guys, this is a third segment of Office Hours with Dr. Johnson today. Normally with my professor tips, I leave you guys with a tip or leave you guys with a recommendation. But today I'm bringing in my subject matter expert that I know that I work with. For the new folks here, Dr. Lewis and I, we graduated from the same doctoral program together from Nova Southeastern University.
Yes.
We both got our Doctor of Health Sciences, focusing on global health, focusing on health, on higher education and public health. So she's a subject matter expert with the same degree as myself, but her specialty, her niche is public health. So Dr. Lewis, what do you have today for our professor tips that we're going to leave them with?
I just want to say Dr. Shelter is amazing. I want to turn into a student again because she just pretty much taught my class.
Right.
She taught our cultural competence courses.
Right.
Amazing. But we'll talk about that one-on-one. But so the social determinants of health, that's what I have for you guys today. And we know that those are non-medical factors that have an impact on health outcomes. So these are, it includes where you are born, where you work, where you grow. Shout out to Crystal. She said, "Hey, Queen." Shout out to Crystal. Thank you so much. And
can I have two people drop subject matter expert in the chat? I'm smiling again already because once again, I love my subject matter experts. I love when they come up here and so passionate about the work that you do. You see, Dr. Lewis, she getting into it. Can I see subject matter expert? Miss L, I see you. Thank you so much. Dr. Lewis, take it away. Let me sit back. Take it away, ma'am. This is your office hours.
Oh, thank you. Okay, so basically, what they are, you know, that we've been talking about, well, on my page, we've been talking about this past week on the importance of the social determinants of health and how they impact health outcomes.
Right.
And we were mainly focusing on how the social and community context. Let me backtrack a little bit. There are five to the social determinants of health. So the first one is economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. So I just want to take a moment to focus on the importance of building community, our social ties, our social networks, our community networks, and also economic stability. Many people do not, well, loneliness is something that causes heavy, poor health outcomes, especially in minority communities. And it's very important in order, Dr. Shelter extensively talked about mental health today, and she talked about the importance of community and how it's crucial to, you know, have those social ties and have be in positive spaces that can help us move forward in a positive light. So remember, we are humans who are social beings, and connection is important. And social ties are more linked to lower levels of depression, anxiety. Dr. Shelter went into it, so we don't have to dwell on that. And longer life expectancy too. The better your social community, the longer your life expectancy. But my social tip of the day is many people may not know that they can create that supportive system for their loved ones and also get compensated for it. So I want to dive into that. I don't know if you have anything to say before I continue, Dr.
No, I
Johnson.
don't. You know, you have these last couple of minutes to dive into that. Yes, ma'am.
Yes. So the research has shown that the the stronger the tie, the more supportive the community, the better management of care, especially when it's linked to related to chronic illnesses.
Right.
So many people do not know that you could become the caretaker of your loved one, and there's a trust factor, right? If I know that it's my sibling taking care of me, my mom taking care of me, my daughter taking care of me, there's a level of trust that I have with that individual. Okay.
Mm-hmm.
And it has been proven that the overall quality of life is improved over time as well. So I always encourage people to check in with the elderly centers in your area to see how you could go about taking care of your loved one and also getting compensated for it. Remember, I mentioned 5 domains, which are pretty much umbrella terms, and the other one that I want to, and you know, the one is they relate to each other. Building social ties, helping your loved ones, getting compensated for it will not only increase your mental, your physical well-being, but improve your socioeconomic status. So that's your financial situation. Okay, you're doing that. You are doing this to improve the life of your loved ones, but also improve your income. But the other thing I wanna add is that across the board, we have seen education and income is equal. It has a major impact on health itself. Okay. So the higher your income, the better your health status. Right. So as you're taking care of your loved ones, you're also taking care of yourself in different aspects. So
right. I love that. Dr. Lewis, thank you so much for sharing that. And Crystal, I see what you said in the chat. You said that you've worked within advanced care planning and quality of life is impacted in a positive way when the person is heard and dignity maintains intact. It definitely is. Thank you so much for sharing that. You see all of that clinical experience and all that healthcare program management experience you got, Crystal. Higher education would love to have you teaching courses. Dr. Lewis, you're another professor. You see Crystal's credentials. She could work within human
Yes, I
services.
see I see Crystal's
You
credentials.
you
I
could
see Crystal's.
definitely work within human services, or even they will
Amen.
even have you teach healthcare courses as well too. But definitely
Yep.
higher education is another segue for you to continue utilizing your acquired skills and knowledge, Crystal. Okay,
Right.
Dr. Lewis, thank you
Uh,
so much. Oh,
oh,
how
I
you gonna
just
wrap it
wanted
up?
to add. I
Sure,
just wanted
sure.
to wrap it up by, talking about how to become that caregiver, right? The
Mm-hmm.
first thing is assessing your loved one's needs. Okay, see what they need. Do they help need in cooking, cleaning, going to the hospital? You could get compensated for these basic things that you do for your loved ones. Okay,
Right.
creating a plan and also getting educated as well. So you create a plan. You get an assessment either by your state or by your local agency, and
Mm-hmm.
they could help you create out a detailed plan of care for your loved ones.
Right.
Getting trained, so we know that education is important too. Get those credentials, all right, and make sure that your space is safe enough for you to move forward as your caretaker. But you have to remember that when all that is said and done, your loved one has to state that they want you as a caregiver as well. So that's an important thing to remember as well. Yeah.
Right.
But check in with
Right.
your local social services, your local elderly agency, and get that information.
I love that. Thank you so much for sharing that, Professor Tip. Today, I'm going to go ahead and drop you down. Continue showing
Thank you so
up.
much.
Continue doing the great work that you're doing. I appreciate you so much, and we love all the work that you're doing as a public health professional and as a professor, Dr. Lewis. So, can we get just a quick round of applause for Dr. Lewis before I drop her down? Can I just have her? Can we let her see her flowers, please? Just a couple round of applause in the chat.
Yes.
A couple round of
Shout
applause
out
in
to
the chat.
Crystal's comment. Thank you so much, everyone. Shout out to Crystal's comment. Compensation can decrease caregiver burnout. Absolutely, it can. It can.
Exactly. Dr.
And
Lewis,
improve both your situation. Yep.
exactly. Why? Because healthcare, do it with me. Healthcare is collaborative. Do it with me.
Collaborative. Yes,
Healthcare is collaborative. Okay.
Yes,
Dr.
it
Lewis,
is.
thank you so much. I appreciate you. Okay.
Enjoy. Bye.
Bye. Okay, y'all, we're gonna wrap it up. We wrapping it up. This was good. I ain't got nothing else for you. I'm tired. I'm hungry. I gotta go eat. We wrapping it up. Can I get a couple deuces in the chat? We wrapping it up. Couple deuces. Dr. Lowe, I see you. Crystal, I see you. Lux Without Borders, I see you. Mia Blue, I see you. Thank you so much. I appreciate you. Piles, I see you. I appreciate you. Y'all got me to over 150K likes. I appreciate y'all. We wrapping it up. Hey, 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 I'm hungry. Hey, we wrapped. This was good. Her Divine, I didn't know you was here. Her Divine, I see you. Blessed Believer, I see you. I appreciate y'all so much. I appreciate you so much. We're gonna wrap it up. Good night. Right now, I just